Hello everyone. You're very welcome. My name is Tom Barker from Health Systems Global and the Institute of Development Studies. Thank you so much for joining us on this webinar today, hosted by partners of the private sector and health thematic working group of Health Systems Global. I think we're good to go. Thank you so much for joining. I can see a number of you are coming on stream very quickly, which is brilliant. I'll give it a few seconds just to see as we hit close to the 100 mark. Okay, I think we're getting there. I'd like to introduce our two facilitators for this webinar today. First of all, Priya Balasubramaniam from Public Health Foundation of India, and also Jerry Bloom from the Institute of Development Studies. They will be taking you through this webinar and hosting this conversation, so I'm delighted to hand over to Priya.
Great, thank you so much, Tom. Really appreciate that. And good morning, good afternoon, good evening to all our participants, and welcome to this webinar session on managing new kinds of public and private health partnerships during and beyond COVID-19, leading to accountable and equitable mechanisms of engagement. This is the second of our mutual learning tri-series on redesigning health systems during COVID-19 and beyond. Thank you all for being here. So a quick outline of our agenda today. We'll start with a brief overview of who we are and what we hope to accomplish from these series. This will be followed by a 90-minute roundtable dialogue by our wonderful panelists. This webinar is being recorded and will be available through our Unconference website, the PSIH website, or emailed upon request. We are also live on YouTube. We'll share that with you towards the end of the session. And we'd like to invite you, our audience, to ask questions during the webinar through the Zoom Q&A function, which you'll see on your screen, which is open and available to you on your control panels. As well as being able to type your own questions, you can also upvote questions that other audience members propose using the thumbs up button on your Q&A panel. And towards the end of the webinar, I will draw on some of those questions to field to our panel at the second half of the session. So without much ado, I'd like to move on next to who we are. So we are the private sector in health thematic working group. We are part of a larger global health community known as Health Systems Global. And essentially, we are a network of health systems researchers from both the global south as well as the north, who have been focusing on better understanding the role and the diversity of the private sector. And we're especially interested in how and what kind of evidence is needed to better engage the private sector as well as the government in partnering on interventions for strengthening health systems capacity towards universal health coverage. We work by contributing to new kinds of thinking about the performance of mixed health systems, building new partnerships for research and learning, such as this series, as well as biannual and triannual meetings to share evidence. Next. So what is the purpose of all this? So this mutual learning series really came about from a series of consultations that we've held from 2018 through 19. This particular series is a short tri-series that focuses on the different dimensions of engaging with the private sector or non-state actors. Our first meeting focused on health systems capacity and service delivery. The second one will now focus on the management and governance of private sector or non-state actors and mixed health systems. And our third meeting, which will come up towards the end of August, will really knit the outputs of these two on the role of evidence in engaging both public and private stakeholders. The main objective of this series is really to generate some fresh ideas on how private health service delivery and access can actually engage researchers or the research community and the development community to partner more effectively, both with governments and public health mechanisms across populations and levels of care. one of the outcomes that we're seeking is to create a collaborative platform of shared value creation and alignment through both evidence as well as opportunity between non-state actors and the government in identifying health priorities for interventions as well as mutual engagement in order to strengthen country health systems. And next, please. So this goes on to why. Why are we doing all this? And I think one of the abiding reasons is that COVID-19 has changed the health sector landscape in many, many ways and exposed several fault lines in country health systems as well as strengths. And part of this series is to try and understand what makes who are the different kind of actors that make up mixed health systems. There are a variety of providers in terms of ownership and relation to governments and regulatory systems. There is a need to ensure and access to affordable mix of preventive and curative services, and at the same time reduce the risk of dangerous and exploitative practices when dealing with the private sector. Yet in all this, there's often very little clarity on the actual mechanisms of engagement between non-state actors and the state. And this series is to really throw some more light on how those partnerships are evolving, what are the mechanisms that can make them happen, and what can really, and how is the post-COVID world really going to look like when you have two sets of actors contributing to one country health system. So I'll stop over here, and in the next slide, please, hand over to my colleague, Dr. Gerald Bloom from the Institute of Development Studies, who will present some of the key takeaways from our last roundtable that was held in June, and also what to expect in today's webinar, along with some of the results from the registration survey that many of you have so kindly contributed to. So over to you, Jerry, and I will come back at the end of your bit.
Well, first, welcome everyone who've joined this meeting. I thought I would tell you, just because it's always interesting to know who the group is you're part of, that around 400 or a bit more registered for the event, although a smaller number have been able to join. What was interesting is 70 of you were from Africa, 110 from the Middle East and South Asia, 130 from the Americas, 50 from East and Southeast Asia, and 50 from Europe. So a very big geographical spread. And we have people who joined who are in the private sector, work for government, NGOs, and multilateral organizations. So it gives you a sense of the breadth of people who are now interested in this topic. We asked some questions, and I don't think I'll try to go in detail, but you can look at these three slides. Basically reports back what the people who registered felt were the most important issues. So you can see this slide on the current and emerging issues, on the role the private sector providers play in enhancing health systems accountability, and finally, on how research evidence can support the development, implementation, and evaluation. So again, a very big mix of people and a mix of questions. So we know there's wide interest, a lot of questions. This follows on a meeting we had on the 24th of June. There we had 3 parallel breakout sessions, each with about 12 people who reflected from different aspects of the private sector. And their key messages came out as follows. Everyone saw that the private sector and non-state actors have responded quite rapidly in various ways to COVID-19, and not much is known about this experience. Clearly, we need new approaches to monitor performance and curtail profiteering or predatory practices. There's specific concerns about the need to avoid duplication of effort between the public and private providers to know who is responsible for what. It's clear that governments, regulatory agencies, non-state health providers, and citizen groups all will need to assume new roles and responsibilities if what's emerging were to lead to changes at scale while avoiding bad outcomes. And there's a need for evidence on what has worked well, what innovations have not succeeded in meeting health needs. Now, we're in a period of crisis and rapid change, And those periods are the times when new realities can start to become evident. And I think what we've decided with this meeting is, rather than have the breadth of discussion, to have a small number of people from different parts of the emerging new health sector to reflect on the experiences they've had over the past few months and some of the implications for the future. So first, we're just asking them to look at the new developments, new understandings that are emerging as people are grappling with the problems. You'll notice we have very different perspectives. There's no one picture of what's happening. And we need to try to put together a picture from the different points of view and different perspectives. And ultimately, we'll ask for a few reflections on what are the implications for the future. So I think we have the opportunity for a really exciting set of discussions. Back over to Priya to introduce the panelists.
Thank you, Jerry. And now it's my pleasure to introduce our panelists for today. So bringing in a policy perspective to this roundtable, we have Ms. Sujatha Saunik, who is the Additional Chief Secretary in the Skill and Entrepreneurship Department, Government of Maharashtra, India. She's worked at the state level as Principal Secretary of Public Health and Financial Reform. Ms. Saunik has been responsible for shaping and implementing policy in public health across cross-cutting areas and developing through multiple partnerships, various stakeholders for health systems reform as well as capacity building. Welcome to the table, Ms. Saunik. From an intermediary role, we have Ms. Carolyn Mbindyo, who is the CEO for Amref Health Enterprises Limited in Kenya. AEL is a social enterprise arm of Amref Health Africa and is responsible for the incubation and commercialization of locally developed healthcare solutions across Africa. Ms. Mbindyo has extensive experience in testing technologies and innovations and also developing new kinds of business opportunities through public-private partnerships in emerging markets. So welcome, Caroline, to this roundtable. And then we bring in, and I hope Dr. Sahili has joined, but as part of the private sector hospitals, we have Dr. Mohamed El Sahili, the Chief Vision Officer of Medland Health Services in Zambia. He's both a doctor and a healthcare entrepreneur. Medland Health is the first hospital in Zambia to use cutting-edge digital technology, which has been integrated into models of care in the hospital sector. So welcome. Then presenting a technology perspective, we have Ms. Claire Morris, who is the International Programs Director of Babylon Health and is responsible for developing Babylon's global health portfolio. Babylon is a UK-based digital health service provider that provides remote consultations with both doctors and healthcare professionals using an AI-based platform with mobile and telehealth services. They've recently committed to a multi-year partnership with the government of Rwanda. And finally, last but definitely not the least, bringing in a legislative and regulatory viewpoint, we have Mr. Anirudh Rastogi, who's the founder and managing partner of Ikigai Law, a boutique law firm which is headquartered in New Delhi in India. He's advised several cutting-edge technology ventures that include space missions, cryptocurrency exchanges, drone usage and manufacturing, and telehealthcare companies. So definitely a very wide perspective there. So welcome to you all for this panel discussion. And I will now hand over back to Jerry to moderate this first round of discussions, and we'll be back with curated questions from you, our audience, at the latter half of the session. So see you on the other side. Over to you, Jerry.
All right. Well, first, again, welcome to the panelists. And we'll ask each of them to give some initial reflections on their recent experiences, and then go to hopefully more of a discussion between them. So first, I'd like to ask Ms. Sujatha Saunik, what are the main challenges that you've experienced as you've increasingly involved the private sector in the government health services in your state? What are the issues that you would really like us to pay attention to? So over to you.
Hello, everyone, and thank you, Jerry and Priya. It's wonderful to be part of this esteemed panel and have people listen in from all across the world. I will start with a brief introduction of what I have been doing in these last 3 to 4 months, and then come to the points that Jerry wants me to cover. So in my current assignment as Additional Chief Secretary of the Skill Development Department of Government of Maharashtra, I also lead something called the Maharashtra State Innovation Society. And on your screen right now, you have a list of various startups and the work that they have offered in these recent months. And you can see the wide variety of the technical solutions that were made available. This was under the ACT grant program, which was basically a group of venture capitalists who came forward and they said that they would support government action wherever required in managing the health systems, which were already very much under stress because of the COVID pandemic. And so ACT Venture Capitalists gave us the initial funding for this, and we worked with them. So today I'm going to cover two things that we were able to do in these preceding months. The work done under the ACT grant program, as well as the work done under the Maharashtra State Innovation Society. So to continue, this society was set up in 2018. The main objective of this society is to provide support to new startups, and not only because they provide jobs, but also there is a wide network of legal and regulatory systems that they have to navigate. And the primary job of this society is to provide them that support. When the COVID pandemic started in early March, in Mumbai, we activated through this society an online platform where we could exchange information with all the various actors and stakeholders, both who were willing to help through funding. Largely it was corporate social responsibility funding, and those who were willing to provide the solutions, both tech solutions as well as the hardware. And so with this goal in mind, we started to run the platform to bring the government agencies, hospitals, managers, the municipal corporations of Mumbai, Thane, the entire state, as well as other key functionaries who were given various responsibilities to interact directly with the tech providers. And this worked very well in the initial weeks. And slowly there was a dialogue that was set up. We were able to provide good quality relief material like PPE kits, like N95 masks, ventilators, etc., obtaining the same through donations, which was quite unparalleled in the state at that time. When a pandemic rolls out, you often find that you are hard-pressed for getting your systems going, and the society could fill that gap at a very, very important time. We raised donations worth over USD 4 million, which is 30 crores in Indian rupees in kind. And we did not take any funds from anybody directly. The money was used to pay for the goods that were being made available to various partners. The society then also worked on the food distribution piece, which became imperative due to the huge migrant crisis that followed, one of the largest ever labor movements which the world has seen in recent past. The society facilitated transactions over $2.6 million, which is about 20 crores in Indian rupees, on food in the food distribution network. Beyond facilitating donations, the Innovation Society also developed tech platforms in partnership with the industry, with a strong focus on quarantine tracking, telemedicine. Some of the startups in the Innovation Society's cohort also developed innovative COVID-19 focused solutions like mobile apps and platforms where information could be exchanged easily. In doing all this, there were many issues that we faced, but I will talk about that a little bit later. Moving on to the ACT grants, these were all people who had a stake in the way the government was responding to the pandemic in the state, and they were willing to step in and offer the solutions to whoever would want to use them. And one of the biggest learnings at that time was that when a system is under stress, it can only take that much. So while tech solutions are the way forward, we found that in the course of our work, there was a particular limit up to which it worked, and then there were issues that came up when we wanted to continue using these solutions. And another important area that emerged was also about the data collection under these various these various tech solutions. Can we please see the next slide, please? Just so everyone gets to see the kind of, different partners that we worked with. And one example here that I would like to give is about the ventilators. We initially got, indigenous ventilators that cost us about $3,500 in comparison to those which are much more expensive to be deployed in the government hospitals. But we found that the acceptance of those ventilators within the management and the human resource available at the hospitals, who were also under tremendous stress at that time, was a little bit difficult to handle. So we have faced questions about, what is the best fit for providing services. And the other challenge that we felt that emerged slowly was, how do you manage all the logistics when you're having thousands and thousands of things coming through donation? You also need a logistical manager within the government to take care of all that is coming and making sure that it is reaching to the locations where they are most required. So in this way, we were able to initially raise a very coordinated response, build credibility in the system, provide a sort of a platform where information could be exchanged. Our job was to make sure that whatever we were putting out was authentic, credible, and reliable. That does not mean that we did not face challenges and issues, but I suppose that is something that I can cover as the conversation goes forward. I think I'll stop here, Jerry.
All right. We heard about the initiatives there. I wonder if we could hear Dr. El Sahili. First of all, welcome, and thanks for making the effort to join. I know it was somewhat complicated. I wonder if you could share what is the experience of Medland Hospital been in response to COVID-19? And really, it'd be good to get your reflections on how can a private hospital such as yours contribute to government efforts to provide universal access to hospital care? What are your reflections on that? Welcome.
Hi, thank you, Jerry. I'm sorry also for the quality of my camera, but we were facing a technical problem. So, as a facility in Zambia, let me say first that the approach, not only in Zambia, in the continent, was to let everything related to diagnosis, treatment, and follow-up of patients with COVID-19 being managed by the public authorities. Therefore, the private sector role has been a little bit delayed, let me say. However, this was not a reason for us not to first be prepared and to deal with the situation. So the moment we have seen the first few cases of COVID-19 in the region, we have activated our response committee and as well as our campaign. So basically what we have done is that we went through two roadmaps, one that is designated to public and to the general community by providing them more and more information about the COVID-19 crisis and how to deal with it. And on the healthcare part, what we did is that we made a plan to based on levels, so from 1 to 3. Unfortunately, now in Zambia we have reached the level 3 at Medland Hospital, and therefore the whole hospital was split in 2 zones, green and red, with a buffer zone in between. This gave a little bit more of confidence, of trust, of a safety feeling among the patients and their relatives. We had to take some decisions that at that moment were seen unnecessary by the public, such as, for example, restricting visitors or also introducing virtual consultations. So all these have helped us to prepare ourselves internally to the level 2 and level 3. At the same time, we went into we went into talks with public authorities, but also other partners from the private sector, whether present in Zambia or regionally, to see how we can best cooperate so that we can together fight the outbreak. For instance, we have activated our laboratory. We have done a training while we knew that PCR testing is not allowed for private sector. We went through a proper training to our team, and we kept on asking when can we be accepted as a diagnostic facility, at least for PCR. And the moment we have been approved, you will see that Medland Hospital is now working hand in hand with private facilities and with the public sector in order to support more testing being done and more screening being also offered to general communities. We are also working with the public sector in terms of how to, at best, arrange for referrals of positive patients from private facilities, mainly Medland Hospital, to the public facilities, and in case of no capacity at designated public facilities, how we can at best treat the patient or follow up the patient in-house at Medland Hospital. We also have engaged the public sector through a training program that is now in process, so that we can train more and more nurses as well as lab technicians, because this is one of the challenges that we are all facing, especially in our region, shortage in in manpower. At the same time, we also try to create a certain way of restructuring the supply chain when it comes to drugs and consumables, because Zambia is a landlocked country and we needed the efforts of everyone. I will be more than happy to go into details of what we have done and what we are doing as part of sharing experiences, but since it is very wide, I would be more happy to talk in details about a specific subject that may be of interest of the audience today.
All right, thank you very much. And we may ask you to, as you think about it, to look a bit at the future, and how can you see a hospital like yours contributing substantially to government strategies for increasing access to hospital care for all. But I think in the meantime, it would be good to go to Carolyn Mbindyo, and ask her, for us that don't know, what is the role of Amref Health Enterprise in enabling the private sector to contribute substantially to government strategies for making progress towards UHC? And how do you see its role developing to support improvements at scale?
Mm-hmm. Okay, thanks, Jerry. Hi, everyone. Warm greetings from Kenya. As I think you can see from what the first two panelists presented, there is no argument that the challenges in the health sector are complex and they require a whole of society approach to solve them. So the public sector, the private sector, and what I call the third sector, which includes nonprofits, it includes social enterprises, etc., need to work together for health, social, and economic development. So at Amref Enterprise, we see ourselves as having like three key roles in enabling the private sector to contribute substantially to government UHC strategies. First, looking at us ourselves as brokering trust capital. Where I come from, there is a saying that goes, if you're peeling groundnuts for a blind man, you must keep whistling so that he knows you're not eating them. So we see Amref Enterprises as a trusted broker who can work with both the public sector and the private sector, keeping positive social outcomes and commercial opportunities in our lens. An example, in Kenya, Amref Enterprise, together with a consortia of partners, including the government, non-profits, multiple pharmaceutical companies, and grassroots communities, are deploying an initiative whose goal is to build a model for high-impact NCD services that is sustainable and that can be replicated across multiple countries. A second role we see for enterprise, for Amref Enterprise, is really to be able to create go-to-market pathways for social innovation. Today, there are hundreds of innovations that could positively transform the health sector in Africa, including improving outcomes at health facilities, providing personalized care to patients, reducing cost of care, and bringing diagnosis closer to communities, which I believe my fellow panelist, Claire from Babylon Health, will speak about shortly. For many reasons, very small portions of these innovations move beyond a pilot phase. So at Enterprise, we know that innovation is about people. We work with entrepreneurs to pressure test their innovations. Be they digital tools, medical devices, softwares, process changes, or any other innovation. We want to really understand what is their efficacy. How do the communities who are supposed to use them perceive them? What are behavioral considerations for adoption? What policies, regulations, guidelines do we need to consider or to comply with in order to bring these innovations to scale? Where is the evidence of impact in our context? So these are the types of questions that we ask so that together we can create go-to-market pathways for social innovations that make the difference between failing and scaling. If I can give a quick example of what we've been doing during the COVID-19 period, because of course COVID is novel, and a lot of the health workers, in fact, none of the health workers really understood how to manage what they didn't have the right information, and they needed their capacities built all the way from the community level to the healthcare and the specialists in facilities. We deployed a platform that was being used primarily in Kenya and scaled it very quickly to Ethiopia, Uganda, Malawi, Zambia, and currently we are rolling out in Rwanda and Tanzania, all within a very short period of 4 months to be able to build the capacity of the health workers who are supporting COVID-19. A third role that we see for enterprise, which is also related to the second point of scaling innovation, is we see enterprise as making it possible for public resources to be used to purchase innovation. At Amref, we see health as a common good, and common goods do not typically align with the rules of demand and supply, and therefore have a high predisposition to market failure. So when we look at health needs, including health innovation, we see them as being primarily funded by public resources. But we know public resources are scarce and they are low risk, which means they are not best placed to purchase innovation. So at Enterprise, first, we work to de-risk innovation so that public finances can be leveraged to support them. And second, we enable blended financing for health innovation. So 3 main things for Amref Enterprise: brokering trust, building go-to-market pathways for social innovation, and creating ecosystems for public investment in innovation. So if nothing else, COVID-19 has really shown us the importance of cooperation, of collaboration, of coordination across all sectors. And I'm happy to speak more about how we see this shaping out as we build back better. Thanks.
Well, thank you, Carolyn. And I'm sure we will take you up on the offer. So it would be good to hear your thoughts on Build Back Better. And also, how would you play how do you see your role growing over the next few years if some of these interesting innovations, which are at small scale, actually are to be transformative? But maybe we should first go to Claire Morris of the International Programs of Babylon and really ask her, as she sees it, what are the major challenges in taking a well-developed digital health service to scale and exporting it to another country? What do governments need to do to ensure that the service can help it provide effective and affordable services at scale? So what is the partnership, as they see it, between Babylon, an international company, and a government in a country that wants to take improvements to scale. I think Claire can't use the video, so we may just have to hear her voice.
Yes, my apologies, and thanks very much for having me, and apologies for not being on video. So, yeah, so I'm speaking on behalf of Babylon Health, which is a digital health company based in the UK and providing a range of digital healthcare services, really from an AI into physical services. So we work with a range of government partnership with both other private sectors, so private insurers, hospital groups, as well as government. But obviously government is core to our mission to delivering healthcare affordably and accessibly for all. And really digital health comes into its own when it is delivered at scale, when it can be delivered at a national level or at a city level to really provide services to those who need it when they need it. And obviously the situation with COVID has provided really, I mean, we were well established in a number of countries and therefore were in a position to be able to support the national initiatives, both by providing users information and advice, and really is a really important transition in the health space, digital health sector as a whole to support. So we see here, but in terms of working with government, a real value of coordination, very much building on Caroline's point, real coordination and coordination across government for digital health to really bring its true value to a national health system. You need to be working with ministries of health, but you also need to be working with ministries of ICT, with other regulators within the sector. So it's a broad range of stakeholders with whom you need to work. There has to be real transparency. And I think obviously digital health provides enormous opportunities for national governments, but it's new technology, it's very fast evolving technology. So I think the private sector and everybody working in this field has a real duty and obligation to really make sure that they are very transparent in what they're doing, very open in what they're doing, and supporting those key stakeholders to build their own capacity, because you need the regulators both within the Ministry of Health and elsewhere to feel that they have the confidence to be able to regulate these new technologies with confidence. And this comes back to obviously what our first panelist was talking about, and how important the government role is there. I think it's also really critical with regard to digital health that at its essence, we have all the relevant clinical assurance and governance processes in place, and that the private sector can demonstrate very clearly everything that they have in place to provide the reassurance around clinical governance and assurance, and whether that's on telemedicine or on AI, that this is a critical component that all of the private sector needs to be able to provide, and provide that reassurance to the regulators. We're seeing, I think, obviously a huge growth and interest in telemedicine and digital health globally in the light of COVID, both in with regards to the symptom checkers and all of the tools that are being available both for patients and users directly, as well as healthcare providers, as Caroline's outlined. And that's a really exciting innovation. But we're also seeing obviously the importance of digital health and telemedicine in providing people with the care and support that they need everything else, all the other health needs that they have that are continuing irrespective of COVID. And that's obviously one of the big concerns and one of the important contributions that telemedicine can make in particular, is to be able to not delay accessing healthcare when health centres are closed or people have concerns over going to health centres. So that's another important piece. We are seeing obviously an openness to reviewing regular medicine, but also some regulations around data sovereignty that makes, and data privacy that will make some of these tools more affordable for governments in the long term. As I mentioned, a really important opportunity here around transition to self-care. And I think as our colleagues mentioned, from Zambia, between public and public sector and private sector, and between the digital and physical facilities, which we think is a really important transition, and I think really important for the longer term. So I think I would leave it there in terms of some of the key learnings from our side, but very happy to answer questions.
Great, thanks a lot, Claire. I think I should say that at some points there were some problems with the sound, so I'm not sure what we can do. But it would be good to get your thoughts when we come back to you on a bit from your experience, what governments or other agencies and countries need to do to be able to make use of digital health services effectively and safely. But I think we'll first turn to our expert on law and regulation, Mr. Anirudh Rastogi, who is a law working in this incredibly rapidly developing field. And we wanted to hear his thoughts on what changes in Indian laws are needed to encourage innovations in healthcare technology, but ensure that these innovations take into account government priorities of ensuring access by the majority to safe and effective services. So please, Dr. Rastogi.
Thank you very much for that. I'll be happy to take up your specific question, but before that, a caveat. Unlike the rest of my fellow panelists, I'm not really an expert in healthcare, but I think I would be able to add some insights to this conversation by virtue of my work on legal issues and also policy advocacy for a number of emerging technology industries, technology segments, especially those that are regulated ambiguously. So, I think technology is going to play a very key role, I think, in achieving our UHC objectives, and especially in the times of this pandemic as well. As we've seen, there's been a major, push towards enabling telemedicine, contact tracing apps, etc., to enhance the capacity of the state and the private sector in deploying healthcare. Now, as we see more and more of this push towards use of technology to scale, and obviously we want to, we want to do as much as we can to enhance this. How do we look at designing regulatory frameworks that enable innovation at scale? And I would like to begin with a very fundamental premise here, which is that we should have clarity over what should be the objective of regulation or the regulator or any regulatory system, which to enable innovation. And I think it is important to acknowledge that the objective of the regulator is not only to contain risk. It is not only to mitigate risk, it is also to enable innovation. And that mindset is very important because if you don't have that, your energy is focused on, or you become very risk averse in the way you deal with any new business model, new system, new technology. I'll give an example. I'll go back to the 1860s when automobiles were first introduced in London. There was something called the red flag rule, which was a law that required any automobile to have, in addition to the driver, at least two other people. One person who would be a trained mechanic, who would be able to essentially ensure that if the automobile were to stop on the way, then this person can fix it. And the other was actually supposed to walk at least 6 yards in ahead of the vehicle with a red flag in his hands, ensuring that people get out of the way of the automobile. Now, clearly the objective here, right? The regulatory objective here was risk averse. It was not to enable innovation. That was at least not the primary objective. I think a related point there, and I will come to some more specific examples from the healthcare industry as well. But a related point here is that any regulation that is meant to enable innovation in a new field should not have a zero risk tolerance. There will be failures. I think the idea is to have the right kind of balance to ensure that you achieve optimum, you enhance innovation but balance risk, and you have a risk-based approach as well. So for example, if I were to talk about the telemedicine guidelines that have recently been introduced in India, and I'm going to take that as an example to make a number of different points. I think the guidelines provide that you can very well prescribe, say, a paracetamol on the phone, but narcotics cannot be prescribed remotely at all, right? So there's a risk-based approach rather than a principle-based approach, and which I think is a good way to regulate any kind of new technology-based model, because you also are at a loss to exactly quantify risks in all cases. Another related point I want to make is the need for a light touch regulatory mechanism in general. Whenever you're regulating a new technology, you having a heavy touch mechanism to regulate is bound to fail. It is bound to be very rigid, and it's going to fail to keep pace with the way with the pace at which the technology itself will evolve. At the same time, it needs to be technology agnostic, right? So again, taking the example from telemedicine, if your telemedicine guidelines were to supposedly provide that, were to envisage the providing healthcare or consultation only over a certain technological medium, say for example the telephone, or it may not contemplate your ability to do so over WhatsApp or social media, and that will be a disaster. I think so. You have to have any regulation needs to be technology agnostic if it has to enable rapid technological or rapid evolution with technology. It should also be non-prescriptive. If it is very prescriptive, very detailed, again you're going to have the same problem, and we keep hearing that regulation is always playing catch up with technology, right? So again, in the telemedicine guidelines in India, something interesting they've done is that while the regulations, the regulations generally are not very detailed, not very prescriptive, but they comprehensively cover all, broadly lay out the principles that need to be followed. But what is very interesting is the principle of reliance on a doctor's judgment, where the guidelines say that, well, a doctor is ultimately supposed to, apply their own judgment and their own professional judgment, and in a way that professional judgment in a particular fact pattern will trump that everything else that is in the guidelines. So an approach like that, which allows for discretion, which allows the doctors to also increase their reliance on technology in a way that they feel that in their discretion can be will serve the purposes of a particular, will best work in a particular situation. Now, I'm going to move from here to talk about self-regulatory mechanism, because obviously
try to wrap it up in a minute or so, please.
Sure, that's all I'll take. Yeah. So self-regulatory mechanisms, essentially, because we've been talking about mixed health systems where public and private partnerships. I think it is very helpful if in various cases, if regulation could be left to the industry on a self-regulatory basis, where the government can lay down broad principles that need to be adhered to, but leave it to the industry to essentially lay down the kind of the more micro aspects of how it wants to regulate itself. Again, such a light touch regulatory approach ensures that you have more flexibility, where the industry is of course closer to kind of how technology is being how technology is evolving, the needs of the industry, etc. And you have a little more flexibility in this kind of mechanism. So I'm going to stop there, and maybe we can take this forward in the Q&A.
Well, thank you very much for all the panelists, and I think for all of us, well, for me, I mean, what again is being demonstrated is the amount of experimentation and new thinking that's emerging, really just, I'm sure based on a lot of previous work, but that's really coming to the surface now. First, I'll just ask if any of the panelists heard something that stimulated them to want to come back or to develop an idea before I ask another question. Okay. Okay, please, Ms. Saunik.
Just a quick comment. I really enjoyed listening to Anirudh and his point about, what did he say? A light touch regulation. I think that's very interesting. I would like to explore this a little bit more going forward. But I think the important point here is when you're talking about regulatory or ethical issues concerning digital health tools, what's very important to remember is that they are all dependent on the human resource. So it's not just that you can use a tool and replace a doctor. Even in telemedicine, you need a doctor to provide care. And the idea of using telemedicine in countries like India is emerging because of the shortage of health staff, and telemedicine can provide those services to a wide range of patients who need it at a critical point of time. So it's an interesting concept, but I would just caution that, using technology also at the end of the day requires human resource, trained human resource to use it.
I wonder if you've stimulated Carolyn or Claire to make a comment. Carolyn, do you want to comment on this? Because I know you're doing a lot of work in this field.
I do. I think that was a really interesting discussion, especially around what role innovation and how do we embed innovation into public health systems. And I think I mean, looking at it from a public health practitioner's lens, there is a very specific duty of care, and there's a certain threshold of evidence that is required for innovations to be accepted, to be embedded. And in many instances, that level of evidence, just because evidence has been shown in one country, one geography, one region, it doesn't then translate to say that it will be acceptable globally. So really thinking of these regulations, these policies, and how do we build, if we look at the manufacturing sector, there are standards within the manufacturing sector that if you meet certain minimum global standards, then we are able to use the product across multiple geographies. When we look at innovation, that is not necessarily the same. Even if an innovation has been proven in, let's say, Dublin, it doesn't mean then it will be proven in Kenya because the health contexts are so different. So how do we take this into consideration as we think of embedding innovation?
I mean, I wonder if Claire has a comment. I guess I'd ask Claire, because you've been working for quite a while in the UK, but also in a number of other countries. I mean, from your point of view, first of all, what do governments need to do to be able to use the kind of technology you're talking about effectively? And I guess we're also mentioning regulation. But on the other hand, what does the industry need to do in order for governments to trust them, to be able to regulate themselves and do things effectively and in a trustworthy way? So Claire, I wonder.
Yeah, no, absolutely. Very, very happy to comment on that. I suppose a few points. Obviously, there are a range of different regulations and standards, and certainly around data and so forth. There are obviously, GDPR is a European standard. We adhere to that, and we maintain those levels of standards wherever we operate in the world. So in the absence of national standards in every country. You do your best to adhere to the highest possible standards. So, and that gives, I think, to your point, Jerry, reassurance to governments who don't yet have some of those standards in place, if you see what I mean. With regard to telemedicine specifically, it's a very interesting one because in many ways, you can regulate it even more carefully than you can regulate a normal health provision. So for example, in our case where we're providing telemedicine, we can audit all of the consultations that happen. Whether they are audio or video, those can be audited. So they are audited by both the clinicians themselves to self-assess, as well as by our clinical supervision. So there is a level of transparency and audit that is possible with telemedicine that is not in fact possible during your a normal health provision. So that's just an interesting element to bear in mind. But I think coming back to your question, Jerry, I think it's what's really important is obviously building your evidence base, and this comes back to the research, building your evidence base, sharing the lessons learned. As Caroline said, obviously there will be some lessons and experience and research that is less relevant between one country and another, but it is really important to show where you are, what guidelines you are adhering to, what regulations you can adhere to, and what lessons you can bring from other contexts that could be relevant to support national regulators to develop the frameworks that would give them the confidence to take.
Looks like we've
Sorry, Jerry, did you catch that?
No, we lost the last minute.
Oh, the last minute. So I was just saying that I think it's really important that the private sector then take the lessons learned and the regulations that they've used in other contexts to support governments who have not yet got those regulations in place, to give them the confidence to take these innovations to scale.
But then, and I think we need to wrap this discussion up so we have some questions. I guess, I mean, what I take from this discussion, even in this very short time, is a number of developments. There's an increasing language, an increasing wish to use that jargon word, build back better, that something different is going to emerge after this pandemic. And that one possible aspect of it is a much more effective collaboration between the public and private sector, but to meet the population's health needs. So I would ask, particularly from Sujatha Saunik, I mean, in where she sits, with the great expectations that are going to be coming your way in the next year or two, what would need to be done to give you confidence that private providers will perform well and be seen to perform well and protect you from the political fallout of bad things happening? What would you need in a small number of messages? And to the others, what are your key recommendations if you're come to in this meeting, we're going through a pandemic. We hope that we're going to get a better health service later. Maybe your top 2 or 3 recommendations about measures needed to increase the contribution of the private sector to government's efforts to meet health needs for all. So 1 or 2 key things that need to be done as people come together to say, how do we move forward in a productive way? Sujatha, first maybe your comments. You're the one that's going to bear the risk.
Thank you, Jerry. I'm happy to. So first of all, I feel that some of the best and most fruitful partnerships are forged when you are in the middle of a crisis. And they can also provide, long-term solutions to some of the issues that we are discussing. The second point is that going beyond COVID-19 also, if there are mechanisms created for these kind of interactions to happen between the private and the public sectors, they can go a long way in continuing the dialogue which you started during a crisis. Now let's first agree that these are 2 very different worlds. The rules that they follow, the way they work they are very different. And even within the government, there is always a sense of, being averse to the way the private sector works, in the sense that we have very strong rules and regulations, we have codes of conduct, we are accountable to the legislature and to the media, and all political governments are also very much answerable to their electorate. So whenever decisions are taken, they have to be based on sound evidence, scientific, information. You need to work with experts in that sector. In the current scenario, it's the health sector where we need to work with technical experts, people who understand what is to be done and prioritize it effectively. And most importantly, I think the way you commit to the use of public funds is something that in the long term can always be questioned if you have taken decisions which in the ultimate end did not work for what we call the larger public good. So as long as these basic principles are taken care of, accountability is taken care of, and the private sector is happy to collaborate under a certain set of business rules, I think it always works out. I saw in Maharashtra, for example, when we were equipping the largest government hospital, it's called the JJ Hospital in Mumbai. We set up the lab in record time to build our testing capacity. And we reached out to companies such as Kiagen, and we raised money from a variety of donors. It happened in record time because of the very clear goal that we had set, that we need to boost the testing capacity, and we were able to do it. The second example here I would like to give is there is a trust hospital in Mumbai. It's called the Wadia group of hospitals. It's a mother and child twin hospitals, and we needed to build COVID specific facilities and wards for the treatment of pregnant women and their babies. And this also happened in record time because there was a clarity of purpose. The hospital gave all the information that was required to the private sector, and the donors, they had a round of meeting with the management people, but it all worked out in the end. So what's important, I think, is trust. I think it's sharing of information. It's also being honest about what are your boundaries, that you are not in a position to cross certain lines because there's a hierarchy, you report to that. And to be able to appreciate that within the private sector also there would be certain constraints that they will not be able to go beyond. I think that helps.
And just to add to that, do you have any particular advice to the private sector about what they need to do in order to more effectively now engage at scale in your state?
Yes.
What do they need to do to enable you to be able to do that?
I think we've already made considerable progress in terms of, getting to know each other. I think what's important for the private sector is also to understand what the priorities of the government are. There could be certain solutions that they're bringing to the table, which we may not be in a position to adopt immediately because we are focusing on something else. So sort of getting that right fit of connecting with those priorities of the government, that I think is key. And more importantly is to be able to continue the dialogue. Processes within governments take time. You have to be very perseverant. I think also you have to be a little bit more persuasive. So as long as you are determined to work together, I think it always works out in the end.
Okay. I mean, Andrew Stogie, when you have to boil it down to saying to government and to the private sector, what would be your top 2 or 3 recommendations that people need to achieve once the pandemic hopefully is controlled and people are thinking, now how do we build back the health system? Just two or three key recommendations.
Sure. I mean, I think, in fact, one recommendation that I could draw from a question that Caroline raised as well, which is that how do I, take something that has worked in Dublin to say Johannesburg now, because it's a different context, and how do I make it work? And I think there is a role for, I think the answer to that is just, an open mind towards piloting new ideas, new models very, very quickly. How do we devise a system that helps you do these pilots? And I think this is important not only for the private sector, but also for the state. How does the state enable these kind of pilots very quickly? I think experience with sandboxes in multiple different industries can be could be used for healthcare as well, quite well. Where not only does the industry get an opportunity to try out new ideas, but in a safe space where the regulator is closely watching and relaxing certain regulatory requirements to allow you to do that. I think that could be a powerful idea to launch new ideas in public-private partnership. And there's one last point on that. I think there's a lot of learning which is not only for the private sector in rolling out an initiative like this, but for the regulator, because when you are able to now, work so closely with a private company in doing a pilot, and the learnings from that pilot then, kind of inform the regulation as well as the business model as well. I think that by itself is powerful.
Okay, so very much the need to see this process of change as one of learning and experimentation. Dr. El Sahili, your advice to government and the private sector about what would need to change in order for hospitals like yours to make a greater contribution to government health sector objectives? One or two key pieces of advice. Yeah. Please.
Well, we have, as a private sector, we just have to keep on noticing that yes, governments are maybe slow, but that is not an excuse for us not to engage with them. So I think the best that in our region, at least, the best that governments can do is to update the regulations in a way that it can facilitate for the daily operations. For instance, if we are going to implement an automated dispensing system of drugs in hospitals, there must be a mechanism to allow such regulations, because this does not exist, or it was not existent before, and we have to support that. The other thing is that we have to put or to find a way so we can plan better how to keep some facilities mainly green and some other facilities yellowish or red. We cannot just become we cannot turn all of our existing facilities that are already lower in capacity to the existing demand. We cannot turn them all in red hospitals, because we still do have patients in cardiovascular surgery, onco patients, orthopedic patients, and they need clean and on all levels departments. So I think the best is also to encourage the private sector themselves to go into a kind of agreement on how to be prepared together, because as a private facilities with the government, we have to make that exchange. For instance, we have patients that are suffering from neurological symptoms, and we may not have at Medland Hospital a neurologist per se. So we must facilitate a real partnership between public and private. We have to create a way of circulating doctors, nurses, skills. The same applies also to our supply chain.
Thank you. So governments and hospitals need to spend more effort in coming to agreements on mutual roles and responsibilities.
They need to talk, they need to engage, they need to create a channel of communication. We cannot just encourage people on using cashless methods, for example, and we did not engage with Ministry of Finance and with the Bank of Zambia on how to reduce the bank charges. The same applies to mobile money. We cannot just keep on encouraging people on using mobile money, and we did not have a proper channel of communication with ICT players, because these are the ones that will help us. We cannot encourage people to pay online if we don't have a proper gateway softwaring of payments. So it's really a long-term thing. At the end of the day, this is not a trial. We all know that this is something that we are living, unfortunately, on a day-to-day basis, but lessons have to be taken so that we can face much better coming pandemics.
Thank you very much. Claire, your key 2 or 3 recommendations on how some of the benefits of digital health can be taken to scale in countries?
Well, I think it comes back to the key government players, the key stakeholders having enough information and capacity to feel that they can take advantage of organizations, NGOs, and the private sector sharing and coming to them with initiatives and ideas, but also helping those governments to build. It is a question of persistence and patience and transparency, but I think there are huge opportunities here to take advantage of these technologies to prepare for the future and to really strengthen health systems for the future. But it's also understandable why governments can be a bit wary of the many pilots and the many innovations. I think it's fairly overwhelming. So I think also there's an element of greater coordination and responsibility across the health sector here as well. For real transparency in what everyone is doing. Me there, Jerry, sorry.
Okay. Well, thanks. Carolyn, your key recommendations about what needs to be done in the next year or two and how you see it.
Yeah, I think from just a necessity point, public health has operated from a scarcity mentality. So, why things are not possible, instead of really asking, how do we make things possible? And I think now is the time for us to ask what is needed and how can we make that possible? And we have seen with this pandemic how many things that we thought were not possible actually are indeed possible. We have seen the adoption of technologies, be they in health facilities at community level. Zambia has talked about what is happening with trying to encourage mobile payments. In Kenya, for the longest time, we knew that the ceiling in your wallet, your mobile wallet, was 140,000 Kenya shillings, which is around $1,400, and it was doubled essentially overnight, so that's to encourage mobile payments. So a lot of the things that we thought were not possible indeed are. We have seen governments taking up a lot of digital tools, even to really support the work that government is doing at the national level, at subnational levels. So I think right now is the time to ask, how can we make things possible, as opposed to starting from the scarcity point of we cannot do this. We have seen, ICU facilities across much of Africa, multiplying significantly to be able to address what we perceive as the challenges of COVID. So I would say that what I see happening is us looking at public health and at partnerships with the private sector, with the public sector, as really asking how do we make this happen, as opposed to saying that this cannot happen.
Thank you. Well, I think before I pass you on, I think we have a lot of questions. I just want to, thank the panelists for really excellent discussion. I guess what I heard, and I'll just leave it at that, from Carolyn, change is possible and improvements are possible. And I think that's the key. A lot of emphasis on the importance of trust and accountability, that governments have to trust that things will go well and that people will perform well, which means, as Dr. Sahili said that we need engagement by both sides to negotiate roles and responsibilities, and the responsibilities as important as defining roles. And we've had a discussion about the importance of testing new things, but not too many, in a coherent way, and developing evidence about what works well and what can be taken to scale. So an excellent discussion. There's a lot of questions, and I'll pass you on to Priya now to bring some of the questions to you.
Thanks, Jerry. Yes, we do have a whole bunch of questions, and I'm hoping that we will try and get across a few, given that we don't have too much time left. But there are quite a few questions on the role of regulation that have kind of evolved as the discussions go on. So there's I'm actually combining a few. So there's one on something that Anirudh brought up, the notionality of light touch regulation. So the question, I think, is from Bierger, and he says, would not light touch regulation require serious commitments to self-regulation and accreditation among private providers? And do you not think that private sector themselves don't seek to ensure quality standards and eliminate potentially harmful practices? This kind of segues around another question around how can we trust the private sector to self-regulate if there's no transparency in the first place? So I think we could put this question across all panelists, since there is some form of regulation in many of the innovations and interventions that you're involved with. So why don't we start with Sujatha and kind of end with Anirudh, and then I will bring forward one or two of the other questions that are more specific to panelists as well.
Yes, thank you, Priya. I think I already mentioned a little bit on this, but I'm happy to say a little bit more. You know, regulation sometimes becomes important because you are answerable to other agencies. It's not just a bilateral interaction that you're having, that it's you know, a particular government agency or a department, ministry, which is interacting with a particular agency, but all your actions are scrutinized later on by other agencies. And so you have to be able to show to them that whatever you did at that point of time was in the best interest of the people and the problem at hand. So it's you know, it's always something that is a little bit of a tightrope walking. It's not easy, and this light touch regulation is a very welcome idea, but I don't see it really taking shape immediately, not at the moment in the present set of circumstances. Perhaps once the worst of the pandemic is behind us, we could certainly engage in some sort of a dialogue to understand each other's positions and try and make some progress over there.
Great, thank you, Sujatha. Carolyn, would you like to comment on this?
She may have lost her.
No. Yes. So I think that because that there has been shown that there is an interest from government to work with the private sector, the challenge is real. The government doesn't always trust the private sector. The private sector mostly feels that governments are bureaucratic. Citizens often feel that private sector is very, you know, capitalist. So how do we find a meeting point where we can really work to the benefit of each other? So I don't know that there's an easy answer, but what COVID has shown that it is possible. And because I see, you know, we will be in this COVID period for an extended period of time, at least months, before we see a vaccine coming. Hopefully during this period, that is some of the things that we will be working on. How do we continue to collaborate effectively? How do we continue to partner so that each of the sectors can be able to listen to, you know, why does government require so many regulations? Why are these regulations in place? And how can they be designed in ways that enable these partnerships? How can private sector address the needs of the citizens, not just those who are able to pay, but all those who need the services that are being provided? So I think there is room for dialogue, but I don't see that it's going to be an easy walk in the park.
Great. Thank you, Caroline. I'd like to just take that question over to Dr. Sahili and actually pose a rider, which is another question. One of the questions that was actually posed to you is that did Medland accept patients from public hospitals in cases where public hospitals had already reached their capacity? So I guess, how I'd like to structure the question on light regulation to you is that where, at what point do private sector hospitals become accountable to kind of really engaging with the public sector at times of crisis? So, for example, is Medland accepting patients from public hospitals, and what are your thoughts on having a regulatory framework that holds you accountable to be able to provide both, healthcare that's for public good, but at the same time balancing your own, role as a private sector provider?
Thank you, Priya. Let me tell you that the moment you decide to go into this business is the moment you have to accept that you shall not wait for someone to regulate you, but you have to abide by the existing regulations and push for an update of those regulations. You cannot just wait for the public sector to come and engage with you. So you are accountable the moment you get into this business. And the moment you do that, at least this is what we believe in at Medland, you have to work hand in hand with everyone, your colleagues in the private sector, whether NGOs or facilities or whoever is there, even the insurance companies and the public sector, to ensure that the health and medical services provided at least do share the same level of quality. The difference between private and public sector is mainly related to the hospitality services that we may offer that may be a little bit different than those that you can have in a public hospital or facility. Therefore, if Medland Hospital is asked to admit patients coming from public sector, yes, we will do so. At this stage, we have not been asked to go into that road. The only scenario that we have faced so far is when we had already an inpatient who was tested COVID-19 positive, and therefore we were asked to keep the patient in our facility due to capacity restrictions, whether it is related to ventilator capacity or to bed capacity. But we have not yet faced a scenario where, for example, a patient was in a public facility admitted and we were asked to admit in our hospital. Although I repeat, this should not be something to think of. It's our mandate to serve everyone. And honestly, this is not, I'm not throwing people with flowers or with nice words. This is what we believe in. If we would like to differentiate ourselves as a player in the market and mainly in the private sector, it is by bringing in new services that are not existing at the public facilities, and therefore this is where we will be playing an extra role as a private sector. But when it comes to, for example, this COVID-19 crisis, where we know that the medical service can be provided in any facility, it is our duty to make everything happening so that the level of care is the same in both sectors.
Great, thanks. Thank you, Dr. El Sahili. I just want to kind of move that question to Anirudh. Again, we're talking about regulation, but one point that you kind of brought, which is very interesting to me, was that what can the health sector learn from non-health sector in the field of regulation where partnerships are concerned. I mean, the health sector, I feel, is still in kind of nascent stages in trying to kind of establish these mechanisms of engagement with the government, with the private sector, and between the private sector themselves. And health is a very complex enterprise. What can the health sector learn from non-health sector in managing some of these more complex relationships? Can you, and just give me one example. We have 5 minutes to go, so
Sure.
please. Yeah.
Sure. No, thanks, Priya. So I think everything that I've spoken about, especially concepts of light touch regulation or sandboxes, are concepts that are not new and have been tried out in multiple different sectors. And there are learnings where these concepts have both succeeded and failed, right? So there are all these learnings which definitely can be adopted by state and industry in the health sector as well. Now, if I were to take just one example of light touch, just because there's been a fair bit of discussion on this earlier as well, I think light touch regulation does not mean that we take regulation lightly. Because it's a different approach to regulation, but you're as serious about regulation as you should be, right? It's not a new idea, as I said. There are examples of success and failure as well. Now here, there was somebody posed a question that how do we ensure that the private sector is kept maintained? I mean, when you do not have trust on the private sector, how do you ensure transparency? How do you ensure that they? How can you trust them with regulating themselves essentially? Now, one thing we need to understand: the reason why light touch regulation has worked in certain other industry segments is because the industry also realizes that if they are not able to effectively self-regulate, then the regulator will be left with no choice but to come in and increase its own regulatory capacity, right? So there is very clear disincentive or incentive within any light touch kind of regulatory framework for the industry to maintain the highest standards of regulation. Having said that, there are tremendous examples of failure. The entire banking crisis in the US, I think in 2007 and 8, was attributed to some extent because of the tremendous amount of kind of an increasing light touch kind of where the central bank was giving way to the private industry to essentially regulate itself. So there are learnings of success and failure, but I do think that this is something where you can learn a fair bit from other industries.
Thanks. And I'd actually like to conclude, and we're really out of time, but I'm just tempted to ask one last question to all the panelists. You have exactly 30 seconds to kind of give me your thoughts on this. And that's, what have you learned about public and private collaboration from this COVID-19 crisis that you think will change business as usual? This is a question from one of the attendees, and I think it's in your sense, what do you think has fundamentally changed in the way the government and non-state actors are cooperating and collaborating, and where do you think that changes? 30 seconds, and we'll start with Sujatha, and we'll go through to Amref.
Yes, thank you. I think a beginning has been made. We have been able to start talking to each other. We have learned a lot from each other. And our laws now also permit setting up of, technology incubation centers using corporate social responsibility funds, something that we are very much keen to explore. We are also in the process of now setting up a startup, center where we can allow for different virgin and greenfield experiments to be done, to have better collaboration and linkage with some of the government's priorities. And all this has happened because of the initial work that we have done together. So the sky's the limit, and definitely there is more trust and there is more respect for each other as we go forward.
Great, thanks. Caroline, 30 seconds. What has changed fundamentally in your opinion?
I would say how the importance of the global public health to the economy. I think that has shifted so significantly, and looking at what then that same economy, what corporate sector needs to do to ensure that the public health systems are strengthened so that in the event of a similar crisis in future, and it is coming again in future, that we are better prepared for it.
Great. Claire, 30 seconds. What do you think has changed fundamentally due to COVID that will have long-lasting implications in terms of public-private collaboration?
I think a fundamental shift in seeing the opportunity of digital health. I think in terms of government collaboration with the private sector, recognition of the need for speed and the need for innovation. We've really seen it in COVID, and I think that has changed some of the thinking within governments about how they recognize and see the value and importance of speed and innovation.
Thanks. Thank you so much. Dr. Mohamed El Sahili, you have 30 seconds. What are the 2 points you'd like to make about fundamental changes between public and private?
I think the main change is that we reached a stage where we were able to bridge the gaps that were resulting from the lack of trust or confidence in between both parties. Today, we have communication channels that are really open, transparently, and with full accountability and will to cooperate. And I think that today the public sector is also ready to accommodate the creativeness and the innovation that is brought by the private sector, and the private sector is also willing to applaud the regulation that are mainly related to data sharing and to exchange of skills and empowerment of local skills. This is my view.
Thank you so much. And finally, Anirudh, you get the last. What do you feel has fundamentally changed with relation to digital technology, in relation to healthcare and public-private cooperation?
Sure. So two things. One, I would just like to echo Dr. Saunik's point about, the best partnerships are forged in times of crisis. So the kind of collaboration we've seen between private and public sectors is unprecedented right now. The second thing, and I'm quoting somebody else here, but I think especially true for the Indian government, the government has, using say contact tracing apps at massive scale in India. The government has begun to, has in a way seen what it can do acting as a product manager of sorts, right? Where state apps, where applications, tech applications deployed by the state can be brought to scale about, like literally across the entire country in a couple of days. And I think that's a tremendous, it's a really interesting start, I think, and we're going to see a lot more of that going forward, I believe.
Great. Thank you so much, Ms. Sujatha Saunik, Dr. Carolyn Mbindyo, Ms. Claire Morris, Dr. Mohamed El Sahili, and Mr. Anirudh Rastogi. Thank you so very much. It's been a wonderful panel, and thank you so much for these really interesting outputs. Thank you, the audience, for sticking with us through 90 minutes. It's been I'm sure it's, you're flooded with webinars across various topics. And if you're still interested in this, please do join us for Roundtable 3, where we actually pull in the role of evidence in engaging public and private sector stakeholders to redesign health systems. And if you want to be a part of it, do write to us, digitaluncon2020@gmail.com. So see you on the other side of August. And once again, thank you all so much for your time and inputs. Thank you again.
Thank you. Thank you, everyone. Thank you to Priya and the co-panelists, and to Tom and Jerry.
Thank you, everyone. Bye-bye.